So I had a talk on the treatment of childhood relapsed ALL at a late time point, so late relapses of acute lymphoblastic leukemia. And the finding for these patients is interesting because these patients are mostly, or let's say the leukemias of these patients are mostly chemosensitive. So that means that most of these patients come into a good remission with conventional induction chemotherapy. And those patients who have a good response to the induction and have also an elimination of minimal residual disease, which can be also named MRD, minimal residual disease. Those patients with negative MRD have a good prognosis with just continuation of chemotherapy, excellent prognosis actually. And those patients who have an MRD poor response after induction, they have a poor outcome without any other intensification of treatment, but with transplantation of these patients, they have a very good outcome. So this is a very clear indication for allogeneic stem cell transplantation. And so if nowadays a patient with late bone marrow relapse of a B-cell precursor leukemia, so for T-ALL is a different story. For these patients, they have a very good outcome in the range of event-free survival rates of 65 to 75%, so really good outcome. That was one of the main messages, that for these patients you can even achieve good outcome data without transplantation. And the next point was to say that there are genetic subgroups among these patients that have rather poor outcome. These are selected little subgroups, and we, knowing these subgroups, we stratify them into the new risk group, a very high risk group, because they don't benefit from conventional treatment at all, and they need to be allocated to experimental treatment. And these are patients with a TP53 mutation alteration, patients with a translocation 119, 1719, with MLL, AF4 translocations, and also patients with very early relapse of ALL, so very early. And so patients with late relapse of ALL without these genetic features, they have a really good outcome. Next point was that nevertheless, these patients need intensive and toxic chemotherapy and stem cell transplantation in part of them. And that there's always a medical need to get rid of these toxic treatment elements and to replace them with less toxic, more targeted therapies. And there are a couple of good results, in particular with the drug blinatumomab, which targets CD19 and CD3 is a bispecific monoclonal antibody, and this attaches CD3 positive T cells to CD19 positive leukemia cells, and so I think the mechanism has been shown and discussed a lot of times. And this is a very effective and a very little toxic drug in this indication, and there are already published data on the efficacy of blinatumomab in patients with late bone marrow relapse of B-cell precursor leukemia and MRD poor response, of those who need to be transplanted. For these patients, there are published data that blina is effective. And for the other ones, so the MRD good responders that don't need to be transplanted, for these patients, there's a trial. There has been a trial conducted in the COG in the United States, and the results of this trial will be reported very soon. And it seems to be that there's also a very good outcome in these patients. And so we have one mechanism of action with which we can replace toxic chemotherapy, and this is a progress for the treatment of leukemias.